Call upon Dr. Tania. She is going to present on management of fungal mass confined to the preseptal region of an immunocompetent patient.
Good morning, everyone. So I will be presenting my case on management of fungal mass in a 37-year-old. So this was a 37-year-old male who presented to us with a painless swelling in the left lower lid for last 6 months. It was progressing in size and there was no history of any other recurrent swellings, trauma, surgery, diabetes, hypertension, tuberculosis or any other disease. So he was an immunocompetent person who has suddenly presented with a paleness from last 6 months only. So the swelling in the left lower lid, it was in the preseptal region when we inspected it, and when we palpated it, it was firm, it was mobile and it was non-tender. There was no bruit. The eye examination, rest of the eye examination was totally within normal limits. The visual acuity was 6.6, N6, both eyes, and the interior segment and the posterior segment were both within normal limits. Extraocular muscles were also normal. So diagnosis of a cystic lesion in the preseptal region was made. So potential diagnosis, we thought why it is that firm to the, specifically when we touched it, it was very firm to hard to touch. So we went for a cyst of a bacterial origin, tuberculoma as a differential diagnosis, or orbital lesion of unknown origin. So, so as we proceed with any other swelling, we went for a CT. The patient could not afford an MRI, so he went for a CT. And also we went for a FNAC. The FNAC showed that there was inflammatory exudate and there were fungal hyphae present in the mass. And the CT showed that there was a well-defined preseptal region, well-defined complex cyst in the preseptal region in the left lower lid with the extension to the inferior aspect of the left orbit, abutting the lateral inferior rectus muscle, and they suggested histopathology for the same. So we went with a subciliary incision, and as you can see there is a whitish mass which was even bigger than what was there in the CT. So subciliary incision was done and the cyst was isolated. We aspirated certain amount of pus which was white, totally white and thick, so that we can reduce the size of the mass, and the excision biopsy was sent for histopathology. Fungal cystic lesion was confined to the preseptal region in an immunocompetent person, and the histopathology report showed markings of for a chronic infection. It came out to be aspergillus. So discussion, the extracorneal space, as we all know, contains fat, blood vessels and sensory nerve endings. Common lesions which occur in the extracorneal space are schwannomas, cellulitis, lymphoma or any other infections. So bacterial pathogens are common, but invasive fungal infection, though rare, are critical, especially in immunocompetent and diabetic patients also. We have seen all the COVID era where we have seen different type of cystic fungal infections which were occurring, but this was a rare case which presented now. Hemangiomas, rhabdomyosarcoma, tuberculoma and abscess, often linked to trauma or surgery, are found. Fungal infections mostly are linked to mucormycosis and aspergillosis. Aspergillosis was the case which was in our patient. So non-invasive aspergillosis mostly occurs in immunocompetent patients as fungal balls or allergic sinusitis. So management includes surgical debridement. Surgical or antifungals are, oral antifungals are not mostly used, but we did give it to our patient because he was really worried that it may reoccur. So this case is basically a rare instance of fungal granuloma in the preseptal region of an immunocompetent patient, and we emphasize the diagnostic challenges in the importance of culture testing for every FNAC should be done. Awareness of fungal infections of preseptal region is important, and early surgical excisions with oral itraconazole is what we recommend. Thank you.
So Dr. Saab, I have a few comments.
Yes.
So you said it was a preseptal.
Yeah, sir.
So preseptal means it hasn't gone into the orbit.
Yes, sir. Ma'am,
So
it did
why
not.
are we discussing orbital lesions?
Yes, ma'am. I
So-
agree. But in the MRI, in the CT, it
Exactly.
showed,
I was coming to that.
Yeah.
That your examination missed out a very important point, which was the
Extrapolate.
hypoesthesia on the face.
Yes, sir.
So that should never be missed,
Okay.
right? So that is a very important point. Second was that if you see that MR carefully, the maxilla of that side has the lesion.
Yes.
So it is not purely preseptal, right?
We
And
did
my
go for-
third,
yeah.
my third comment was that I see in your surgical photograph that you've held the tissue with an Alice forceps.
No, ma'am.
You've held the skin tissue
Yes,
with
ma'am.
the Alice forceps.
Yes, ma'am.
Now, Alice is not that, if you are an oculoplastic surgeon
ma'am.
or talking of aesthetics, I would suggest that you keep a single fine muscle hook.
Okay,
See,
ma'am.
the plastic surgeons have this very beautiful instrument.
Yes, ma'am.
It's a very fine hook. So just elevate it with that, and in case you don't have it and you're a strabismus person, then you can use your simple muscle hook for that.
Okay,
See, Alice is going to be very traumatic
ma'am. Yes,
to the
ma'am. I
skin.
agree. Yeah, I
That,
agree.
that was my comment.
I
Thank
agree.
you.